It's unfortunate that helping pregnant people with a substance use disorder is an underserved struggle filled with misunderstanding. So we're very eager to discuss this topic with you all today. And we have two of our best with us to help us unpack both the medical and behavioral health components of this topic. Dr. Heidi Ginter brings her experience as a physician to ensure Right Use program provides only the best medical care to our patients. Board certified in family medicine and addiction medicine, Dr. Ginter has the clinical and administrative experience to achieve results that consider the perspectives of staff, patients, and payers. More importantly, you are about to witness her contagious passion about addiction treatment. She's joined by Michaela Taylor, Brightview State Behavioral Health Director for Ohio. She has helped make Brightview what it is today, a champion of quality care. Michaela is a licensed professional clinical counselor, and her experience in outpatient addiction treatment makes it a perfect complement to Dr. Ginter's perspective. And with that, I'll let Dr. Ginter begin.
Excellent. Thank you so much. One of the things I'm going to do during this talk is start out with a little bit of level setting. What's that? Are you able to hear me okay? Yeah, great. So I want to level set because one of the things that happens. Mute. Okay, I think I'm unmuted for real. Okay, so I want to start out by saying, as we begin this topic, just by hearing the name of the topic and then by looking at our faces, you're already starting to have some assumptions. You're already starting to think some things and feel some things. And I want to acknowledge that. One of the things that I want to do at the beginning is just spend a moment introducing myself and having Michaela introduce herself so that you know what our orientation and our bias is toward this material, so that as you're forming your own beliefs and thinking what you're thinking and feeling what you're feeling, you can also add to it some of the ways that we see ourselves and how we interface with this material at the start before we even dive into the material. So one of the things I want to acknowledge is that I am a white woman and I am a doctor. And those two things, in addition to other aspects of my identity, are places of privilege for me as somebody who is doing work with people who are marginalized. And I want to recognize that identity out loud to let you know that I am oriented as a person with privilege to being an advocate for people who are lacking that same level of privilege. And I want to just say that because as we talk about some of these hard things, and as we really get into what it means to be an advocate for pregnant people who have a history of substance use disorder and are seeking to do the right thing for themselves and their children, including the one that they are carrying, I want us to keep remembering our own lens, because whether you're somebody with lived experience or somebody without that lived experience, I think all of us come to this wanting to do the best that we can and wanting to really help support healthy families. And that's my bias and my orientation. Michaela, do you want to say a few things before I get started?
Thank you so much. It's hard to follow you in that because I think that you put it so well. But I think the only thing I'll add to that is that part of our desire here today is to have this be a message of hope in the way that we have that lens and that bias, that pregnancy is an incredible time for us to serve this population and to be able to serve our communities, and that rather than viewing this as a fearful or anxiety producing, we view this as an opportunity, an incredible moment to be able to walk alongside someone in their journey, and recognizing that that's really the approach that we want to take in delving into our presentation today. So echo everything you say, Dr. Ginter, and I'll turn back over to you.
That's great. So while we've been talking, you've had an opportunity to see what our roadmap is for today. We're going to go into an overview of the landscape and then really dive into some of the challenges, looking at the risks, looking at the opportunities, talking about treatment and some of the specific questions that have already come in from prior to our launching this talk today. And then we'll answer whatever other questions come up. So next slide. One of the things that I alluded to is the idea that you probably have feelings. And one of the things that people often feel and think when we start talking about pregnant people with substance use disorders is this person alone on the side, looking upset, stressed, angry, concerned. What we often don't think is happy mom, happy parenting situation, healthy baby. And what I want you to do is put on the lens of the slide on the side of the happy, healthy family. That is the goal and that is the expectation. And how we get there should be the lens that we're looking at. One of the things I love about the counseling community is the concept of acceptance and commitment therapy, where you are identifying a goal that you're always moving in the direction of. Now, you may never reach that goal, but at least you know what it is, and the steps that you take on the path should be guiding toward the place that you want to get. So if we're grounded in the idea that we're going to have a healthy, happy, successful end to the pregnancy that results in a family that's moving forward in a healthy way, that's where we want to go. Next slide. So one of the nice things about how our regulatory environment supports us in this is that over recent years, pre-pandemic, although now that seems like ages ago, there were a couple of laws that were passed that really provide additional support and access to care for pregnant people, parenting people, and individuals who are trying to navigate substance use disorder care in the context of being pregnant and parenting. And so we can move to the next slide. I just wanted to bring up the piece around what CARA and support bring to this table as we move forward with talking more about pregnant people and how we can support them. So I intentionally wanted to have a triggering photograph here because one of the things that I think often happens in society is that pregnancy is a quote unquote disease that everyone can see at some point. And as soon as you can identify somebody with a targeted condition, particularly pregnancy, everyone's got an opinion. And so you better not be drinking a coffee or having a cigarette or speeding or not wearing a seatbelt or yelling at your kids or having a bad day because everyone around you sees you, identifies that you're pregnant, and then starts to judge. Now, put yourself in the position of a person, whether you've been pregnant or not, who is also struggling with that internalized stigma of, oh my God, I'm using drugs, I'm drinking alcohol, I need to do better for myself, my baby, my family, and I'm afraid to ask for help because if I go to get help, guess what's going to happen? That means I have to tell a stranger that I'm using. And already strangers on the street are giving me the side eye if I, do anything that isn't sort of perfect in terms of how society believes that pregnant people should show up on the planet. So I really want to emphasize this point that stigma really gets in the way, not only the internalized personal stigma that that pregnant person experiences, but also the systemic stigma that they're exposed to. And a lot of times what happens when somebody does get to the point where they're ready to ask for help, they go to a place that doesn't know how to help them, is as afraid of their substance use in the context of pregnancy as they are. And so we are hoping that with this conversation, we can break down some of those barriers. Next slide. And really make the door that the person walks into, whether you provide the services on site or not, at least a safe place where somebody can start to have the conversation and get the resources they need to go to the next location to actually engage in the care that's really going to give them the outcome they're looking for. One of the tricky parts about this is that one of these, not even one, so many things in pregnancy and in addiction are very much myth versus reality, fact versus fiction. Like I often will talk about the idea that somebody holds in their heart that they believe is true because it's what their families told them, it's what their partners told them, it's what they've believed, but it actually isn't true. Many, many, many pregnancies on this planet are surprise, unplanned, unexpected. Most pregnancies are unplanned and unexpected. It's more rare that people identify exactly when they're ovulating, have a sexual experience that is going to result in pregnancy, and then voila, 14 days later, they miss their period and now they know they're pregnant. That is not how it goes. Most people who identify becoming pregnant at some point have already done a lot of things that if they knew they were pregnant, they probably wouldn't have done. And many pregnant people, at the point they know they're pregnant, feel horrible. Oh my gosh, I can't believe I had that glass of wine. Oh my gosh, I can't believe I ate the turkey from the deli. Oh my gosh, I can't believe I was sniffing cocaine with my friends. I can't believe I was injecting heroin last night. I can't believe XYZ. Whether you have a substance use disorder or not, pregnancy finding out is like a really scary time because now all of a sudden everything changes. So this myth of irreversible harm is something that we need to put aside and give people grace and recognize that pregnant people and their fetuses are super resilient. I'm up here in Massachusetts, and so I almost wanted to say wicked resilient. And so for those of you who are in Massachusetts and New Hampshire, I'm watching you. We're wicked resilient. As it turns out, treatment is possible at all stages of pregnancy, and most babies who are exposed to drugs in utero actually turn out okay. Many of the drugs that our patients are using do not cause harm to the fetus during development. You can't tell when a kid is in school if their mom happened to have used during pregnancy versus their friend's mom who did not. Most drug use does not lead to birth defects. And a lot of what we see in children who have been exposed to substances during their mom's pregnancy compared to those who were not, it's really hard to tease out. Was it related to mom's use during pregnancy, or is what we're seeing related to the way in which this child has been raised, or the inherited genetic components that have led to them having neurodivergence that is not recognized and maybe not being accounted for in their school environment or in their parenting environment at home? And so the nature versus nurture piece is really important. Next slide. And I think it helps people feel less bad about what they've done, quote unquote, wrong prior to identifying the pregnancy. So in reality, the myth part aside, the reality is that getting into care matters. So we want the pregnant person to get into care, not only for themselves, but also to make sure that the fetus has the best opportunity for healthy growth during that in utero phase. We want to make sure mom gets addiction treatment if that's part of her desire, which we're going to make the assumption that it is in this conversation. Absolutely mental health treatment. And then recognizing the ways in which social determinants of health may negatively impact that person and doing what we can to provide support. So do we need to give additional nutritional security, a parenting plan as pregnancy gets closer to delivery, safe housing, and all the other things that go along with being a safe human being on the planet? In terms of fetal health and newborn health, it's a lot of the same things. Initiating prenatal care, identifying a pediatric practice that is not going to stigmatize mom's history of substance use disorder or the treatment that she chooses to use during that, or they choose to use during that pregnancy, but really identifying what are the true risks here and how can we treat and manage to reduce the potential harm to those risks that we see. Also, we're going to talk a little bit more about management of substance exposed fetuses and newborns from the perspective of looking at neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. There is a lot of new stuff that's come out pre-pandemic and then a lot of additional studies post-pandemic that are really exciting. And then Michaela will talk more about the involvement with Child Protective Services and a plan of safe care. Next slide. So one of the things that I'm going to brush over quickly so that we can get into more meaty conversations is there are 3 main medications that are FDA approved for use in adults for treatment of opioid use disorder. We're really going to focus on opioid use disorder from the treatment perspective today and not focus so much on alcohol use disorder, for example, or benzo use disorder. But if people have specific questions, they certainly can ask them. In terms of opioid use disorder, medications for opioid use disorder come in 2 flavors. One, and I don't mean the red liquid, I mean, one is an antagonist at the mu opioid receptor in the brain, and that's naltrexone. We don't really use much of that in pregnancy because it doesn't have the same efficacy as the other agonist medications, buprenorphine and methadone. So you can see in my little diagram here, I put naltrexone, I put a meh, because if somebody's on it and it's working well, we're not going to try to change what's working well. If you have a pregnant person who has become pregnant on naltrexone therapy, whether injectable or oral, and they are sober and doing well, there's no reason to rock that boat. They can stay on that medication. However, many of our patients are coming to us either already in treatment on a buprenorphine product or on methadone and becoming pregnant, or becoming pregnant, and that is the impetus to access treatment. And so knowing that both methadone and buprenorphine really have substantial data around not only safety in pregnancy, but also in terms of outcomes for substance using individuals. When you choose an agonist medication, you are choosing the medications that can reduce your risk of overdose and death and have a higher likelihood of being successful in terms of reducing your opioid use and extinguishing the use of other drugs as well. So those two facts alone are super important for people who are choosing medications or who are already on those medications. A lot of times, what do we hear? The first thing that somebody comes into us who's on methadone or on buprenorphine finds out they're pregnant is, okay, talk to me about how I can get off this. And you think, oh, no, you've been sober for 5 months now. Getting pregnant's a really stressful thing, not time to come off the medicine that's helping you. In addition, the question becomes why? Why is that pregnant person wanting to get off their medicine immediately? Or another question that often comes up is you have somebody who's been on methadone for a long time, they've been sober and doing well, they get pregnant, and their dose has been 120 milligrams for the past 8 years. Now they get pregnant and their dose goes up to 130, and then it goes up to 140. And then we put them on a split dose and they've got 100 milligrams in the morning and 50 at night. And then it's 110 in the morning and 70 at night. And now they are freaking out. Oh my gosh, Dr. Ginter, my dose is like twice what it was before. What is wrong with me? No, nothing's wrong with you. As your body changes and you become more pregnant into the late second and early third and then late third trimester, you may notice some things about how you are as a human. Number one, your body's bigger. Number two, you're probably hungry a lot more. You probably pee a lot more. Your metabolism has changed so substantially as your body is doing everything possible to grow a healthy baby. It also is changing the way that you're digesting medicines, including methadone, including buprenorphine. So it is absolutely a physiologic normal thing to have your dose increase over the course of pregnancy and to be on a twice-a-day dose to help you stay comfortable from withdrawal symptoms for the 24-hour period of time. So that's normal. But next slide. A lot of our patients hear what I'm saying, and this is what they hear. Blah, 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 blah. They don't hear, I'm okay, I'm doing the right thing. This is a good choice for me and my family. This is the right thing for my recovery and my baby. What they're hearing inside their own head is, I'm scared about my baby being sick after the delivery. I'm scared about my family seeing my baby suffer because of my addiction, because of the treatment that I chose. Or I'm scared that the Department of Children and Families or Child Protective Services is not going to let me parent as a result of my addiction and the treatment that I chose for my addiction. That gives me shivers and chills when I think about it. Like, what other disease do we vilify patients for choosing treatment in besides addiction? So the disease is as stigmatized as the treatment. And this is so profound for pregnant people. They often will feel like they've made the wrong decision when they choose medication to treat their disease. And we know that this medicine has so much data behind it, so much efficacy, and really great outcomes with babies. So this is an area where I like to spend time talking to our families, making sure that our partners also have the same kinds of conversations about neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. It is not just exposure to buprenorphine or methadone that will cause a baby after birth to have withdrawal symptoms. It's also exposure to the sertraline that mom is taking for the treatment of the depression. It's also exposure to the other medications that they may be taking for their blood pressure or for their diabetes or for their anxiety. Any kind of medication that goes into mom often crosses the placenta and baby is exposed. Now, often what I've heard people say, and this gets into the stigma piece again, is, well, I mean, my mom was on methadone. I was addicted when I was born. You were addicted when you were born? No. You were exposed to a medication that your mom was taking to treat her disease. And that exposure led to you needing treatment when you were born. But you weren't an addict. You did not develop a substance use disorder as a result of that exposure. Now, just because you have withdrawal symptoms doesn't also then mean you are going to have an outcome of developing a substance use disorder as an adult or having bad outcomes in school, for example. What it does mean is that you have a baby who could potentially be suffering, and that baby needs treatment to reduce the suffering and to reduce the harm as a result of the suffering. If you can see this tiny little scale, for those of you who have never seen a Finnegan scale, it is a whole bunch of things about what the baby looks like and how they're responding to external stimuli. So are they crying a lot? Are they very tight in their movements? Do they have increased muscle tone? Do they eat sort of poorly? Do they have a lot of loose stools? Do they just look uncomfortable? And there are all kinds of different ways to score this. And this is a standard way of looking at withdrawal symptoms in a neonate or in a newborn, and then determining based on those symptoms what we're going to do to intervene to keep the baby as comfortable as possible. But I think it's really important to make sure that moms don't get into the idea of thinking, I took methadone, therefore my baby is born addicted. If I take sertraline, my baby isn't born depressed. So the baby is exposed to sertraline. The baby doesn't have the disease of depression. The baby is exposed to methadone, does not have the disease of addiction. However, that exposure is something we need to treat so the baby doesn't suffer. Next slide. And then I had alluded to this really cool thing that has come out, which is Eat, Sleep, Console. So studies were done back in the, I want to say maybe 2015, 2016, 2017, that time. You can go to the next slide. And really looked at if we're going to treat babies who have been exposed to opioids, whether it's treatment opioids like buprenorphine or methadone, or whether it's opioids from the street, whether it's heroin, oxycodone, or fentanyl, obviously much more common now. If that baby is experiencing withdrawal symptoms, is there something we can do to reduce the amount of medicine the baby needs and maybe reduce the amount of time the baby's actually in the hospital? And so one of the things, did we skip a slide? It looks like I may be going out of order, but we'll go to this slide and then we'll go. Actually, do you mind going forward one more to get to the Eat, Sleep, Console? And then we'll go back to this. Thank you. So one of the things that we've found is that as time has gone on and we've identified more babies who have exposure to substances that are leading to withdrawal syndromes, we've found that the idea that it's mom's fault for what they used during pregnancy or what they chose to take from treatment during pregnancy really isn't helpful. What we really need to look at is, okay, how do we keep mom on a safe, effective dose of medication to keep her sober? And how do we then educate her or they in what it's going to look like after the baby's born in terms of withdrawal symptoms and treatment options? I think one of the things that people get scared about related to this is not only their dose going up and making sure that we normalize and explain that piece, but also what's going to be in the baby's tox screen. So there's a lot of fear about what's going to show up in the baby's meconium, which is that first sticky black poop, or the baby's urine. And what happens when the tox screen is positive? How does that impact the family's ability to parent, mom's ability to parent? Go back one slide if you don't mind. This also gets into the overlay of the fear of sudden infant death syndrome. I think that most people in America at some point have heard this and are terrified. And I think that because we've done an incredible campaign around public health measures to tell all people who may have a baby in the house, hey, you got to make sure the baby has tight-fitting clothes, that there aren't toys in the crib, and that the baby's on their back. I think we all have heard that and probably know, back to sleep, back to sleep. Okay. But one of the things that I think our moms who have been exposed to, who have substance use disorders and are now having babies that are exposed to substances, methadone, buprenorphine, whatever other medicines, we have to add an additional layer there of education. Those babies are a little bit more vulnerable and at higher risk for this scary outcome. So what can we do for our moms and families to make sure that they recognize that higher risk is to give them the same education. So if they have a baby who's born early or is a lower birth weight, which are risks for people who have substance use disorders, as well as those individuals who are sober on methadone or buprenorphine, do they know for sure how to take care of that baby and make sure that there's no additional risk for sudden infant death because of this secondary risk that they have from the experience of being a substance exposed newborn? Next slide. And then we can go on to the next slide. One more. Yes. So Eat, Sleep, Console is one of my favorite things that's come out in the past decade. And basically what we've done is identified that when you have a baby who is at high risk for having withdrawal symptoms, specifically those moms who have a substance use history and or have chosen to be on methadone or buprenorphine, we know that those babies are going to need to be monitored for withdrawal symptoms. And in the olden days, what we used to do is put them on that scoring tool and have them scored every 3 or 4 hours. And then once they hit a certain score, they started getting medication. In some hospital systems, it's a tincture of opium. In other systems, it's actually buprenorphine. In other systems, it's methadone. Some systems, they use morphine. And it doesn't matter. It's basically using an opioid to manage the symptoms of opioid withdrawal in the baby, if that is what the baby's experiencing. And what they found is if you actually give mom the opportunity to keep the baby with them, room in, have the baby skin to skin, and really monitor what that baby's needs are and meet their needs in a dyad relationship between mom and baby, where you're ensuring that eating, sleeping, and consoling are really the mechanisms of treatment, the babies don't need as much additional medicine to manage their withdrawal. They also don't stay in the hospital as much time, and their withdrawal symptoms are less than those babies who did not get access to this eat, sleep, console method. So a ton of hospital systems across the country have adopted this, probably primarily because of financial reasons, but for our purposes, this is great for families. This is also great to reduce the stigma that mom may feel having parented or having birthed a child who is now having withdrawal symptoms. There's so much guilt there. But if we then say, hey, mom, guess what? The more time you spend with that baby, the more you have skin to skin. If you choose to breastfeed, do that. All of the time and attention that you give as the parent of this baby is going to comfort them, reduce their withdrawal symptoms, and get them home with you sooner than if you are separated from that baby. So this is a huge bonus for all of our parents who start out with that nervous, anxious, and then all of a sudden, those natural parenting vibes kick in. Or if they're scared, we can help them teach the vibes to kick in and demonstrate that good parenting actually is something that starts from minute one and can really comfort their child and reduce some of these symptoms. Next slide. Breastfeeding, I alluded to, super important to allow for patients to have that choice. A lot of times patients don't think they can. They think it's not safe to breastfeed if I'm on Suboxone, or it's not safe if I'm on methadone, or they think, oh, I'm on too high of a dose, I can't breastfeed. No. Almost everybody who is sober on methadone or buprenorphine has the opportunity to breastfeed if that's what they want to do as part of their parenting choice. All of the major recommendations around this come from everything from pediatrics academies to the ACOG Academy for OBGYN surgeons, as well as family doctors, CDC. Everybody says, no, breastfeeding is fine for these families and these patients. The only areas where there's risk is if you have active tuberculosis or active HIV, or if you have bloody nipples during the time that you're breastfeeding and you have active hepatitis C. What we would do for that active hepatitis C patient is have them pump and dump that milk. And then once the nipples heal, they can start doing the breastfeeding on the breast or continuing to express and feed the baby the expressed breast milk. So hugely important not to count out breastfeeding for patients who just have a history of substance use disorder. We need a little more information to determine what's best in terms of counseling and then helping them make that choice if that's what they'd like. Next slide, please. And then postpartum, this is an area where a lot of stigma comes into. A lot of times people, as I alluded to earlier, get to really high doses of methadone, and then they start to get tired. And as their body starts to return to its normal pre-pregnancy metabolism, they may start to not be able to sort of think clearly 3 or 4 hours after their dose, or may feel really tired or get accused of nodding. What's happening there is their body's metabolism is changing and their dose needs to change too. But it doesn't generally happen immediately. There's generally a delay. So we've got to make sure that we are educating our moms around how they may feel postpartum and when to let us know if the dose is too much. We also want to recognize how stressful postpartum can be. Whether you have a substance use disorder or not, everything changes. the relationships with your other kids, with your partner, with your finances, with your body, with everything changes. And that can also lead to mood changes, that can lead to risks for return to use. It can lead to a whole lot of really challenging circumstances. And we want our moms to feel like they're supported, that their experience is normalized, that they have peers that they can look to who can provide help and can really guide them through this very tricky time. In addition, we want to validate and provide some of that support, but we also want to be realistic. One of the hardest things I think for families to incorporate into their postpartum life is the involvement of Child Protective Services or the Department of Children and Families. And we want to make sure that our families understand what that's going to look like so that we're signing releases of information so that we can communicate back and forth and we can provide support to those agencies that are going to interface with us and really help our parents and our families get to that place where they feel good and stable. And we all feel like that's the safe place for the baby to continue their growth journey through life. Next slide. And now I'll turn it over to Michaela.
Thank you, Dr. Ginter. Yes, I'm going to be jumping into talking about stigma and how that impacts pregnant people and what that looks like. And Dr. Ginter alluded to this earlier, but I think that this is a really key component when we're thinking about serving pregnant individuals and how we can make sure that we are supporting them and navigating through this because of the different barriers that they're facing with stigma. I think the thing about stigma itself is that it induces more barriers. It acts on multiple levels by both blaming people for having a problem and then making it difficult for them to get help. And that's why it's so important that we're thinking through the different layers of stigma that a lot of pregnant people or patients experience and how we can walk along with them in that journey. So I just want to give a brief overview. And there are 3 different types of stigma that can exist, and that's internalized, interpersonal, or institutional. The first one is internalized stigma, and a new pregnant person often believes that they're bad because of the substances they're using, and therefore they delay seeking care. There was a study done that referenced that women or people who identify as such with SUD have a 49% greater odds of incurring stigma than any other identified gender and experiencing SUD, and that there's that extra layer of perception or judgment that people have when you're experiencing pregnancy. And so just having that internal shame that you're struggling with yourself really makes it hard for you to be able to be vulnerable, to be honest, and to be able to trust other people in the midst of this journey. The second piece is interpersonal stigma, and a newly pregnant person who uses drugs could lose previously supported friends or family due to their drug use, and this isolation can really cause a lot of mental health conditions such as depression, increased risk of overdose. There's just a lot of changes going on in this person's life, and instead of having this be a joyous time that they're celebrating with friends and family, this can actually cause them to isolate or withdraw from people because of either the actual judgment they're receiving or the perceived judgment that they fear receiving. And so not being able to have that support and to get guidance and consultation as they're taking those next steps. Next slide, please. And then the third type of stigma that people can face is institutional. And there are 3 different types of institutional stigma: organizational, community, and public policy. And this is really looking at as a society, and as we seek to operate within our organizations, the things that we're putting in place to ensure that we're helping people not have barriers when it comes to engaging in services, getting the support and help they need, and ensuring that they are not feeling fearful of reaching out for help, and that they feel that we are warm and welcoming and wanting to help them navigate through that. I think in looking at those, the last one specifically, whether we're looking at it from an organizational, community, or public policy, we want to make sure that our organization doesn't have negative attitudes, beliefs, or biases that bleed into the way that we operate and how condition or person is treated within an establishment. We want to make sure that we say and recognize that substance use disorder is a medical condition, and ensure that we're applying the same level of perception and support that we would for anyone with any other medical condition, such as diabetes, and ensuring that we're being thoughtful and respectful of the people who are navigating through that. Next slide, please. Punitive measures are not effective. That has been shown over and over again, and I think that's something that we really have to recognize. Is there's a lot of misconception out there that, you know, if I just, this is my time to like hold them accountable, this is my time to ensure that they understand the reality of what they're facing, and almost using fear as a tactic, but that is not successful, and the efficacy of that is shown over and over again to not be something that really serves people well long term or creates the internal support and change needed to help people be successful. Relying on arrest, prosecution, or loss of custody endangers people in that process, because instead of supporting them and encouraging them to get the help that they need, it actually deters them from reaching out and having that prenatal care, having medical advice, having the social services support that they need, and access to the resources they need. And I think that the American Civil Liberties Union called it well when they say these laws are bad medicine and bad policy, that there's not good outcomes outside of them. And we need to make sure that we are changing our mindset and shifting that in the way that we seek to serve people well. Next slide, please. One of the things that often comes up in conversation about serving individuals who are pregnant is CPS involvement, or, you know, whatever the state calls that. And it's a common question due to the fact that there are lots of states that mandate reporting for people who are on any medication, regardless if it's something that they are using illicitly or something that they're prescribed. And so it's really important to make sure that you're understanding your state's requirements for that. And the goal of this really should be to collaborate with partners and to be able to create a plan so that everyone understands what the steps are for this individual, that they feel that they have a voice and empowerment in that, as well as collaborating with legal entities, with other hospital settings, to ensure that we're able to have a plan of safe care in place. So 3 things that I really want to emphasize on this is, in working with CPS, please make sure that you know what the reporting and notification guidelines are for your state and your organization. You understand what their responses to infants and families affected by prenatal substance exposure, and how they support the development of the plan of safe care. CAPTA does require that healthcare providers involved in the delivery of care, or infants born with and identified as being affected by substance abuse or withdrawal symptoms, notify CPS, but they don't distinguish always a definition on what constitutes child abuse or neglect, and what the reporting looks like versus a notification of what that looks like. And so I think it's important that we're understanding the differences of what each state requires and how we can help prepare people for that, and understanding what that looks like, and be able to help eliminate as much as possible or ease their fears, and be able to build a bridge in advance about collaborating with developing that plan of safe care. As always, whenever you are working with a multidisciplinary team, or working with any patients, but especially those of high risk, the best step is always to seek consultation and supervision when determining the appropriate steps to take. That this is a team approach in supporting patients through this process, and this is not something that one person alone should be guiding or speaking to, except for the patient themselves. Next slide, please. The next one I want to talk about is actually, what is a plan of safe care? So plans of safe care are designed to help ensure the safety and well-being of infants affected by infant prenatal substance exposure by assessing the health and treatment needs of the infant and affected family or caregiver. And what's really amazing to see is that developing this in advance of someone giving birth have shown promise in building protective factors for family through social supports, accessing treatment services, reducing the need for child welfare services involvement, and preventing unnecessary family separation, which is huge. And obviously, the goal is, as we said, happy, healthy, cohesive, together family. The goal is not family separation. And so that's huge in thinking through how these plans help create a roadmap for those things. We want to make sure that we can seek to try to have a collaborative relationship, and child safety and permanency, parental recovery, and family well-being always improves when agencies can work together to address these complex needs. Next slide, please. And in plan of safe care, it's covering things such as basic needs, infants' needs, and delivery plan. And this is just a a picture of an example of what a plan of safe care could start to look like. It's a pretty lengthy document for those of you that are familiar with that, and every county often has their own version of what they want that to look like, but the same information is incorporated into that and is meant to be something that really helps pregnant individuals and their families have a plan of how they're going to coordinate, of how they're going to ensure that they have the resources that they need and have the education that they need to help support their needs as well as their infants' needs. Next slide, please. So how can we help overall? In addition to obviously wanting to be educated and make sure that we understand our process for coordinating with outside entities and being able to develop that plan of safe care, the most important thing that we can do is use a trauma-informed approach that incorporates both harm reduction and motivational interviewing so that we can build trust, enhance self-efficacy, and strengthen personal skills and resources that will optimize the health of the individual. The lens that we put on every time that we have the opportunity and privilege of working with someone who is in their recovery journey and also using a substance or in seeking treatment for that is wanting to make sure that we have the right attitude and that we're reflecting on our own personal biases, our own beliefs and systems and environments that we've grown up in to ensure that those aren't clouding our judgment to be able to have unconditional positive regard and be able to build a therapeutic relationship with our patients where they're able to feel seen and safe and be able to know that we're walking alongside them in that journey. We aren't judging them for the things that they're experiencing. So some examples of what that can look like are on this next slide. If you want to go ahead and switch to the next slide. So one is fostering a non-judgmental atmosphere and creating a safe space for disclosure. And an example of that is using person-first language when you're referring to people with a substance use disorder. Language has a significant impact on stigma. You know, the words we use matter is what we like to say at our agency. And we recognize that using terms such as addict or abuser or alcoholic really need to be avoided completely because of the underlying message that we're sending, even if it's not an intentional message, that there is judgment, this is not a safe place to be honest, and there are preconceived notions about how you should be acting or shouldn't be acting when you are pregnant. We also need to advocate for change at all levels. This isn't just something that we should be doing for one pregnant person. This is something we should be doing as a community. We want to focus on the systems level causes of addiction rather than just focusing on the individual themselves and really seeking to help them be in an environment that will support them in their new recovery journey and advocate for change for the things that are barriers to that. We always want to make sure we're modeling empathy and respect, using things such as motivational interviewing and unconditional positive regard when engaging with patients. And patients know that. Patients can sense when they are working with someone that doesn't genuinely have that attitude towards them. And it's important that we are reflecting and being intentional in the way that we choose to show up for our patients. And then promoting access to resources, implementing policies and protocols within each organization that we're a part of that support families, that facilitate that parent-child attachment and enhance the capacity of parents to care for children. I think we want to make sure that we are thinking through what's best for the patient, what's best for the child, and making sure that our goal is as much as possible that those two things coincide together. Obviously, there are always going to be outliers, but speaking generally, we want to help support people in their dream of what they want their future to look like and help make sure that we can eliminate obstacles to help people being together and to being the family that they want to create. Next slide, please. What I really am excited to talk to you most, though, about is patient stories, because Dr. Ginter and I have both had the pleasure of working with different individuals who are pregnant in their own recovery journey. And I think that's a really incredible time to be able to have the privilege of walking along with someone. And so I know that we both would love to share a story. So Dr. Ginter, I'll turn it over to you.
Sure. Thank you so much. Are you able to hear me okay? Excellent. So I'm going to share just a part of a little story, and that is about a pregnant person who I was helping to treat in one of our methadone clinics, who initially had not wanted to come into treatment because she knew that each time she came to the center, we were asking her to submit a urine sample, and she didn't want to have a bunch of positive urine samples. because any positive urine sample, she knows, was going to be reported at the time of delivery and was going to impact her ability to parent. And she had already had her parental rights terminated from prior children as a result of her substance use and inability to maintain and sustain recovery. And so what we told her and worked with her on is to say, we're actually not going to do urines on you. We're not going to check. We're not going to check at all. I'm going to ask for forgiveness from the state and the feds. So we're not going to meet our 8 urines, 8 samples per year for your methadone treatment. And I did, I requested a waiver for that. And then what we said is when you're ready and you feel like it's time that you have a urine sample that you are going to feel proud of, you let us know. And then we'll collect it at that point. So we spent most of the pregnancy adjusting her dose, working with her to reduce her cigarette use, stop her cocaine use, cut back on the fentanyl to the point where she was not using anymore, cut back on the marijuana, like do all the things without watching it in a tox screen, and then checked a tox screen. And the only thing she was positive for at the point where we checked the tox screen was the marijuana and the methadone. And you've never seen somebody so proud and so thrilled. And I think a lot of us were pretty tearful when it happened because it really required us to trust her judgment as a person with lived experience to tell us what she needed to engage with us to get to the point of recovery that was for her and her family. And it was just such a powerful demonstration of listening to somebody's lived experience and walking beside them and respecting them along the path. So that's my story to share.
That's a beautiful story. I love that. Just to jump on that bandwagon, I had the pleasure of working with an individual who had been in treatment with us for a couple of years and found out, surprised, that she had a surprise pregnancy that she wasn't expecting. And this brought up a whole host of emotions and fear, simply because she had actually lost custody of a previous child due to her active addiction. And so all of this came back up with finding out that she was pregnant and fear of that and kind of reliving that experience again. And so what was really incredible was to walk along with her in this journey, because she was in recovery. She was really trying to take the right steps, and she recognized that being able to have the people in her life who were supportive of her, who were not judging her, who were willing to walk along with her in her journey and help her identify what was best for her in this process, was the thing that made the difference, right? That she was the same person, but that she had a different level of support. She had a different level of trust in people, and she was choosing to lean into those things and choosing to continue to pursue her own personal growth journey, and was able to have a successful delivery. And just being able to have her come in and show us the baby or bring pictures and talk about all the ways that she was growing was incredible for our team, just seeing the transformation that took place. And one of the things that I love about this story specifically is that she ended up naming her daughter Hope, which I think was incredible at the time, because to her daughter was a symbol of hope for her, and hope for her future, and hope of everything that she could accomplish. And to me, that was a really pivotal, I think, moment in being able to have the privilege of being and working with her and being her therapist, just to see the transformation and really stick to the idea that pregnancy is an opportunity and a time for hope, versus all of the other things that she had experienced previously. Next slide, please. In summary, some key highlights. There's lots of really great things that we touched on, but some key highlights that we really wanted to speak to today are the following. Pregnancy is a reachable moment for many where positive change is possible. A trauma-informed approach is key to increasing patient engagement and care. This involves building trust, enhancing self-efficacy, strengthening personal skills and resources of that individual, and helping them really feel empowered in that process. Medication for opioid use disorder is safe and is effective. Eat, Sleep, Console is a family-centered, evidence-based model to reduce suffering from NAS and NOWS. Plans of safe care can help prevent unnecessary family separation. It's really important that we're intentional about seeking to help put those in practice with individuals that we serve. And overall, our job as community providers, as advocates, as people who want to walk alongside people in this process is to build trust, inspire hope, and reduce stigma. We really appreciate you being able to be part of this presentation and really appreciate your attentiveness. And we would love to turn it over to any questions that you guys have.
So I'll start with some of the questions that have come through. One of them related to the reporting requirements at the time of delivery. And of course, this is different in all states, but I will highlight what Michaela said regarding reporting versus notification. And in our state in particular, what we've had some hospital systems start to do is experiment with the idea of notification, not reporting. And what that means is instead of letting the CPS know a specific person's name and a specific baby who was substance exposed, they are reporting in numbers rather than specifics. And so it's a notification that there is a substance exposed person and a substance exposed newborn, but not the identification. And that meets the letter of the law and is working its way through our system to see if that's going to be something we can move forward with in a way across our state that is going to really reduce the stigma and the burden of reporting for those individuals who are sober on methadone, sober on buprenorphine, and really get very triggered and stigmatized when they are called out for taking an evidence-based medication for a disease and actually having that disease in control. Another thing that was a question is, what if you have a system of care that really doesn't have a lot of access for pregnant people and you're counseling a person who is actively using and they need to stop using, they want to stop using, but they can't get into treatment for another day, week, month. Like, what do you say? Do you tell them, hey, quit using? Or do you say, using until we get you into treatment? The answer is that you need to advocate so that the pregnant person can get treatment at the moment they ask for it, and work with them to avoid substantial withdrawal symptoms that can harm them and harm their baby, while also reducing the risk of harm from the ongoing use, including potential for contaminants, as well as overdose and death. So I think that we don't want to have people stop cold turkey. That is absolutely not good advice. At the same time, it feels very wrong to tell somebody to continue using. And so the more you can advocate to get people access immediately at the time that they say they need it for treatment, the better. The other thing I wanted to mention was related to marijuana use. Many of our patients believe that because marijuana is legal for recreational use in many states, as well as legal for medicinal use in many more states, that marijuana is actually okay in pregnancy, that it is not as much of a drug as some of the other drugs that they may have used or that their peers may be using. And the truth is that marijuana may be very helpful for some of these symptoms of early pregnancy, but in the long run, it really does have negative pregnancy outcomes like other smoked products, like tobacco, like nicotine, like cigarettes. And so if somebody is coming to you saying, well, it's legal, I can do it. Well, you know what? Like, alcohol is also legal and is clearly something that's not safe or appropriate in pregnancy. Cigarettes are also legal and lead to outcomes with pregnancy that are really not optimal compared to those patients who are able to stop or cut down. And so if somebody is having that feeling around their cannabis use, I would really try to use motivational interviewing to move them along the stages of change from being pre-contemplative into being more contemplative and action-oriented to cutting back. And if they say, but it's helping my nausea, there are many other things that can be used for nausea that are completely safe and really don't have long-term consequences for pregnant people. Many of them don't even involve medicine. And so things like C-bands or things like doing the acupressure points for nausea or having use of the combination of doxylamine and vitamin B6 or other combinations of things that the obstetric provider can give information about if the non-medicine options are not working. Ginger, certain teas, working with our midwifery community on, and even communities of people who are from indigenous cultures where they've never used these types of medications and have had successful management of pregnancy, nausea, and vomiting in ways that are just safe and appropriate. And so you really can talk somebody through that piece around cutting back on the marijuana and really using something that's a little more safe and appropriate. Medication adjustments, we definitely talked about. As pregnancy progresses, people's medication doses, particularly for methadone and buprenorphine, do tend to go up, and that is normal as a result of the changes in physiology that happen to a pregnant person's body. And after pregnancy, those changes will eventually go back to normal. But for those of you who have had a pregnancy in your body and have seen how long it takes to grow a baby, it's about 9 or 10 months, and how long it takes to get back to a pre-pregnancy state. I am now, I will tell you, I am, let's see, 16 years postpartum. And I think that my youngest being 15, like that, okay, so I don't have any more excuses, but if you have a 3-year-old at home, like you're probably maybe getting close. If you have a 5-year-old and haven't had any additional children, you may be getting close to what looks like pre-pregnancy. But I think that that's a myth, that pre-pregnancy state goes back pretty quickly. It's not done at the 6-week postpartum check. It's certainly not done at the 3-month check, and it's not done at 1 year. So people's bodies take time to readjust, and returning to pre-pregnancy dose for many people happens, but for many it doesn't. And that's okay. What we need to do is really look at how that person is doing now in their physical body, however it landed, and then adjusting their medications to make sure that their recovery is supported by the medication choices that they're making and the doses that we're working with them to manage. Were there other questions, Michaela? I don't know if there were things that you were seeing on the chat, or Kevin, that you think we should focus on in our last 2 minutes before we let people go. And we are so grateful that you're here with us. This is really fun.
We have covered a lot of ground in a short period of time. I have not seen additional ones. It looks like you caught the last one from Tanya in this last answer. So I think we're good. We've answered the several that people asked prior to the presentation during registration. So I think we're in great shape.
I think I'll just end with one more thought, and then Michaela, you can close it out, which is I'm seeing a couple of my colleagues on here who have infinite more experience in this than I do. And one of them really talked more about that breastfeeding piece. And that is that if people want to nurse, we really should do everything possible to coordinate that with their pediatric providers to make sure that we're all on the same page, understanding what medicines this person's taking, what the risk to the baby is going to be, and then how can we give the baby the best benefit, that baby mom dyad, around exposure to breast milk if it seems safe. And maybe it's not going to be breast milk only. Maybe there's going to be the substitution or the combination with formula, but just allowing for the discussion rather than having black and white rules about yes, no, this, that. I really think we need to join with our people with lived experience, give them the education that they need to make the choices that are best for their family. So thank you so much for that. And Michaela, take us home.
Well, it's hard to echo any more than that, but I think the last thing I want to add is that just like it's important to do this anytime that we work with people who are struggling with the disease of addiction, it's important that we are choosing to be a beacon of hope and light for them in the midst of this, and that we are choosing to be an advocate. We're choosing to be a listening ear, and we're choosing to help them make the best choices that they can for their situation. And it's not our job to parentify individuals. It's not our job to be their advisor in that way. Our job is to make sure that we are helping them feel empowered in this process versus disempowered, and helping them to feel hope in the midst of everything that they are experiencing. And I think that if we start off with that being our end goal, we are always going to end up in a place that we can feel proud of what we're contributing and bringing to the table. I just want to echo Dr. Ginter and really appreciate everyone joining the call, really appreciate everyone's contributions and comments and questions. And I just want to say thank you. The fact that you're here shows how much you care about this population and how much you care about serving pregnant individuals in your community. And that has the utmost respect for me and appreciation. So thank you all.